Okay, so we are going to have Dr. Cynthia Wang come up and talk about treatment pathways for pediatric NMOSD and MOGAD. She was also in Oklahoma City with us with Dr. Mayo Dreyer. So welcome.
Thank you. All right. Good afternoon, everyone. Let me just make sure this works. Okay. All right. Well, I'm Cynthia Wang. I work at UT Southwestern Children's Dallas. So I'm a pediatric neuroimmunologist, and I'm very happy to see everybody in attendance. Thank you so much, Corey and the Patient Health Alliance, for putting on this event. It's great to see all new and old faces. And I'm up here talking to you, but I've been learning so much throughout the day from your own experience, from my colleagues here. So it's just a great environment, and thank you again. I will talk about treatment pathways for pediatric NMOSD and MOGAD. I know I see only one child patient in the room, but I will guess that most of us were children at one time, and many of us are invested in understanding why these diseases happen to people. And I think sometimes we think if it happens to a young child, then maybe that means that they have some clue about why these diseases unfold. So I will just use that as the reason to talk about pediatrics. And we are so grateful for the companies that have invested their time and energy in studying these treatments, because although they're not FDA approved in pediatrics, we are often using them. I don't have any relevant financial disclosures. I will say that all these treatments are, again, off-label, so not approved for use. I'll discuss the features of NMOSD and MOGAD in children. We'll discuss the current treatment algorithms and strategies. I'm primarily a clinician, and I really get excited to think about how do I sequence these medications and therapies we have available to us inside and outside of the hospital. And then I'll highlight some of the clinical trials being done in the pediatric space, as well as some exciting future directions. So I think everybody in the room has sort of a love-hate relationship with the immune system. We understand it's very important. It helps us keep us healthy from pathogens, viruses, bacteria, fungi. But at the same time, it has a lot of downsides when you are affected with one of these disorders. The other thing we have to consider about the immune system is that it also does surveillance for cancers. So, our cells are constantly dividing, changing, and the immune system is very important into, regulating and monitoring for any abnormal cell or cancer tumor growth. So with that, I think it's important to think about these therapies, and that we do want the immune system not to overreact or misbehave in attacking these things that are part of our own healthy tissue. But at the same time, if we overdo it, then we take away a very important part of our body. Many of you may have gotten diagnosis such as this before you came to a final diagnosis, and I hear a lot of patients asking, why was it optic neuritis, and then they changed it to a different name. And I just want to kind of go over a little bit about the naming or the nomenclature. So the conditions that we know about today affect different parts of the nervous system, the brain, the optic nerves, the spinal cord. And this is sort of how, when you initially present and they see inflammation in XYZ part of your brain or spinal cord or optic nerves, this is how they call it. With the research and the advancements have been made in the last couple of decades, now we can find these syndromes that describe it better, because it can predict sort of what the trajectory of your disease may be. So then you might have modified your diagnosis to one of these, whether it's multiple sclerosis. Dr. Dreyer talked a little bit about the differences. Sometimes in children, we have a condition called ADEM, where we don't actually know what causes the inflammation, but thankfully most of the time it's a one and done type deal. And then when you are finding an antibody or something in the blood or spinal fluid that you can test for, then we give it a more formal name of NMOSD, MOGAD, or autoimmune encephalitis. So this compares NMOSD and MOGAD in terms of what the antibody target is. I think everybody in the room now understands that it's different, and we have to think about them differently, even though some of the symptoms can be the same. And then the affected tissues, I think optic nerve is often the most common place for these conditions, but in NMOSD, I often see spinal cord involvement more than the brain, and then in MOGAD, sometimes it's brain more than spinal cord. The clinical course is really important because we want to know sort of how to treat the disease not only at the time of onset and attack, but sort of what do we need to do for the future to prevent any disease from coming back. And then I think even before we get the diagnostic test, the blood antibody, we can usually generate a hypothesis of what disease somebody may have, whether, they're young versus a bit older, if they're female versus male. And typically you do see a slightly older population, more female predominant, more non-Caucasian races in NMOSD than MOGAD. And they're more likely to have other autoimmune diseases too. So this is the column where I think in pediatrics, it's still it's a bit disappointing. I put together these slides. I think Corey mentioned I saw her in Oklahoma. It was almost a year and a half ago. And unfortunately, it hasn't changed. We don't have any FDA-approved treatments. But we do borrow a lot from what's available in NMOSD in adults. So choosing medications that have similar mechanisms to those has been really useful. And I think in pediatrics, there's one that's approved, satralizumab or Enspryng, for ages 12 and up if you live in certain countries like Canada or Japan, not in the US, unfortunately. And then studies are underway, including the one that has pretty good, initial data, the positive outcomes from the satralizumab study. Okay, I hope this is helpful for many people when they think about, their own condition, how do you think about attack or relapse, and what treatments are used at different stages. So imagine, I think a lot of us use like analogies of, putting the inflammation out or putting the fire out. So if you can think of your body and when you're experiencing symptoms, at what stage may you be in? And here it shows sort of a fire at the very beginning stages where just starting, it hasn't really, grown. That is ideally when we, have you call your doctor, your medical team, and then we can initiate treatment for like an acute attack. Sometimes, it goes really fast and the symptoms get out of control very quickly. But then there will often be a phase, even without, timely treatment or treatment, that fire or the inflammation will sort of burn itself out. And then that is a different phase where you think about different things. Perhaps you don't want the fire to ever happen again, so you need to be on medications that really target prevention. And then long-term recovery, I think this was really great what Dr. Hardiman mentioned about, how do you manage fatigue and other symptoms that are more persistent in the kind of chronic phase of the disorder, and how do you, like Dr. Malamed said, how do you think about what you eat and put in your body, because those are things that really do change sort of, like how do you feel on a day-to-day basis, and they're not treatments that doctors would write. So I think this just echoes at every stage of illness, a different treatment approach may be warranted. So I won't belabor this. I think most people understand that you might get IV steroids, you might get something called plasma exchange, and that might be how they sequence it. You might get one first and then the other. IVIG is often used in centers that are a bit smaller and may not have easy access to plasma exchange. General principles in acute treatment, I like to think, especially if you know what condition that you're dealing with, I think, I've heard a lot of people talk about themselves being patient advocates, advocating for yourself. Like, you have a really key role in understanding your disease. I bet many of the people in the room know more about these conditions than many ER docs, for instance. So please advocate for yourself. If you have a known diagnosis of aquaporin 4 or NMOSD, I think it's very important to use Plex as soon as you can. We know those antibodies are disease-causing. They directly cause damage to astrocytes, and once you injure those astrocytes, you don't get them back. So I think there's a general principle. If I know somebody has NMO or I'm very suspicious of NMO, I use the plasma exchange as early as I can. For MOG, I think it has, it's both what we call very steroid responsive. We know steroids really stop inflammation and stop swelling. But the flip side of that is that if that inflammation is very rapid and we can't get a handle of it, MOGAD can be life-threatening. So I see children where they have the kind of the ADEM variant, the brain variant of MOGAD, and then they have a lot of brain edema or swelling. So I typically recommend for that using steroids. And, we haven't really used these medications that are approved for long-term use as much acutely in the hospital setting, but I've actually had some success using things, IL-6 antagonists, that's similar to the satralizumab or Inspring. We use a version called tocilizumab in the hospital, and I feel like that has really brought down inflammation in a certain subset of MOGAD and NMO patients. And then I think, it's time is brain that often is used in neurology, that the sooner you get the treatment, the better you can recover. And thankfully, with both NMO and MOGAD, these are not conditions where we think that you get disability, outside of the attack. So it becomes very important to treat those attacks as soon and as effectively as possible. But I think the next step often is sort of, where do we go from the acute treatment with NMOSD patients? I heard, some people have gotten rituximab as soon as they got the diagnosis. I think that often is a very wise course because we want to, be very diligent about preventing the next attack. Whereas for MOGAD, it's about a 50% chance if you're going to have another occurrence. So for that, we usually adopt a watch and wait approach. So these are long-term treatments that are FDA approved for adults. I will say I have had some success in getting, one or two approved, but most of the time it's a really long, drawn-out battle with insurance. And, that's something I will definitely do if we need to, but I think it's really important that we now have FDA trials trying to establish that these are both effective and safe in the child population. So, if I don't have the ability to make insurance change their mind and that it is a safe and effective treatment, what do I use? Well, for NMOSD, it often is rituximab. That, is a very important and very effective treatment. And then historically, we've used some oral medications. They are just often so hard. I know myself, and I don't remember to take pills. So that can be really challenging thinking about kids and all their daily activities, and, needing to remember one additional thing isn't always the easiest. With MOGAD, it's different, right? These are two different disorders. We've learned a lot through the day about how they are different. They have different targets. Probably the best data comes from using IVIG on a monthly basis to treat MOGAD. A lot of that comes from the UK and other groups. And, people have hypothesized, why is it, so helpful? I have personally some thoughts. IVIG is like one of the only treatments that is not immunosuppressive. It's actually healthy donor antibodies that you get infused into you. And, in my pediatric population, a lot of kids, they get a cold every few weeks, every month. So is there maybe a role where the IVIG just prevents a child from getting the illness that's maybe keeping them from having relapses? So we do use that a lot. It's still a hard kind of task for a family to, commit to 3 to 5 days of IVIG infusions every month. So what I found sometimes is that tocilizumab, which is a cousin of the Inspring or satralizumab, has been really effective. So for kids that may have relapsed on things like rituximab or IVIG, tocilizumab seems to be pretty effective. And then there are also the options for the oral medicines. So here's sort of the slide. I was hoping I would update this talk, that it would be different, but we're still sort of at where we're at. I think the good thing is that there's definitely movement in all of these trials, and we at UT Southwestern Children's were a site for the first medication, a pediatric trial on Uplizna. So if anybody is needing access to that medicine, please reach out to me or anybody at our center, and we'd be happy to talk to you more about that. And then there's certainly a lot of other sites in the country and around the world recruiting for the ravulizumab and the satralizumab trials. For the MOGAD, there are 2 medications, and I was just gonna I was hoping I would just be able to pronounce this correctly, but I think I also misspelled it, but it's rosanilixizumab. This is a really interesting drug where basically I feel like it's an infusible version of plasma exchange. You're taking antibodies by using a medicine to take out those antibodies rather than taking a machine, to take them out. So this and the other medicine that was mentioned, efgartigimod, are really novel, and I hope that in the NMO and the MOGAD space that medications like this may have a role for people who don't respond to other things. And then satralizumab, which we know from NMOSD, targets IL-6, is also now being studied in both pediatric, age 12 and up, and adult patients with MOGAD. And it was really great to hear from ACTRIMS and that the positive results, and likely, I think the next time I'll be up here talking, this will no longer be under study, but it will be FDA approved. What about where we are now and where we have left to go? I think there's a strong need for more research. For MOGAD, we don't really have a crystal ball. We think maybe half of people who have an attack will go on to have another in their lifetime. But we really can't tell those apart. So one of the areas of research that some people in our center, Dr. Linda Nguyen, for instance, is studying is sort of how can we tell at the very first onset of MOGAD who's going to be a relapse patient versus who's going to just be a one and done and never have another attack. I think that becomes really important, especially if you think about a young person who may need to be on immunotherapy for their life if we don't have a better answer of which path they will take. Acute treatments, I did mention this a little bit, but using things that we often think of as second line as out of hospital treatments like the medication that have been approved for NMO, I think that becomes really important because if you can prevent that complement attack of the NMO at the earliest onset, like while they're in the hospital, should that be used? Does that prevent needing plasma exchange? Is it more effective than plasma exchange? I think those are questions we don't know. And I think for me and our center, we do sometimes get ability to use the IL-6 antagonists, and I think early use of that has been really helpful. So I think that research is really important to know. And then, in children, we have data, but we don't really have the long-term data that we have in adults. So how do we think about, if this is safe and it keeps you from having relapses in a sort of, short-term period? Are you going to be on that for, 40, 50, 60 years? And at what point does that immunosuppression, that kind of double-edged sword of, trying to suppress immune system, but not impeding it from doing the normal things that it needs to do to keep you healthy? How do we balance that? So I think that's really important. And then patient experience. I love days like this because I can hear, I wrote for that treatment, but I never knew that only took 90 minutes or that was just one injection. So I think this is really helpful for me to know, well, I can, a lot of times people, they don't really care the mechanism. They care will they be able to take a vacation or go on a, something else that's really important to them, and how do those treatments play in? So the patient experience becomes really important. And then we're in, Texas. So much of NMO has been, this is kind of a African-American, Black, or Asian disorder, but so many of our patients from this area are Latinx and Hispanic, and they have these conditions. So how much, energy and funding should we devote to that? I think a lot more, just to understand sort of, how their response to treatment, how their disease course, mirrors or does not mirror other people we know. And then I will allude to this. I think, when we think about children, we think, maybe there's also always this sort of nature versus nurture, like how much is your genetic makeup in terms of getting these disorders, how much is environment, so infections that you meet during your life. And I think with children, you can argue that because they're young, they haven't been exposed to the environment as much, maybe for them, the genetic portion is more important. So yeah, I've, a lot of people just stop and say, well, you tested positive for MOG or you tested positive for aquaporin NMO antibodies, and just kind of stop there. For some of my patients, I've looked further and done genetic testing, whole exome or whole genome testing, and sometimes that's found something that was really important, and that might help us understand the underlying basis for why they got that disorder, or even if that condition puts them at risk for other conditions over their lifetime. So I will plug this. I saw this on the the earlier when they just kind of play things. But this is a camp that happens every year in San Antonio. I think applications are open till the end of this month, but it's always such a great time to see children who have these conditions really be able to be themselves, be a child. I hope, one child in the audience will be attending, but it's really great. I think it really just tells you how important community is, that, we doctors try our best, but we don't know the things that, you experience on a day-to-day, and probably the best person to ask are the people who've walked, your shoes. So I encourage, anybody with a child with NMO or MOGAD, consider going to camp. And then just thank you, everybody, for your attention. These are some of the great people I work with. I was really lucky to be funded by SRNA, but so many organizations, Patient Health Alliance, the MOGAD Project, they're all partnering with our industry sponsors to make these treatments available. So thank you so much. And that's it for me.